هشكر وبعدين انت ابتدي على طول.
Good afternoon, everybody. Today is a very nice day. We will have a very challenging multiple choice question, your knowledge in cardiology, and I'm honored to have Professor Jamila Nasr as the supervisor of this meeting, and a lot of experts in the field of cardiology in different fields, including the imaging, the intervention, and the prevention. Professor Bassem Zarif from the National Heart Institute, Professor Walid Al-Awadi from Zagazig University, Professor Taimur Mustafa from Tanta University, Professor Mohammed Zahran from Ain Shams University, Professor Karim Mahmoud from Cairo University, Professor Mohab Magdi from Mansoura University, and myself, I'm Ahmed Farid. I'm lecturer of cardiology at South Carolina University. Dr. Jamila, you can proceed to introduce everybody.
الحقيقة أنا يعني سعيدة جدا. I'm very happy إن احنا to share in this honorable meeting. والحقيقة أنا بشكر الدكتور أحمد فريد لأن الفكرة دي فكرة يعني مهمة جدا. test your knowledge. ويعني أنا بشكره على التنظيم، بشكره على الفكر العالي اللي بيفيد شباب الأطباء. الاستثمار في العلم هو مهم قوي. معانا كوكبة عظيمة من كل جامعات مصر، معانا كوكبة عظيمة من معهد القلب القومي. فاحنا أنا بشكر سيادتك، ويعني إن شاء الله يكون يوم علمي موفق جدا بإذن الله.
شكرا
إن شاء الله يا دكتور أحمد.
شكرا يا فندم. الميتنج والجو ان كل حد من الاساتذه البروفيسورز وهيعرض كيس وعليها مالتيبل تشويس كويستشنز، وهيطلع بول للسلكشن ان البارتيسيبانتس يسلكت الرايت انسر، وبعد كده البروفيسور اللي مسؤول هيقول الرايت انسر هي ايه with a small explanation. Professor Bassem, you can join us please. I think he got offline.
Dr. Bassem, maybe I think maybe he some technical problem. يمكن he is not there. ممكن come the next speaker.
Okay. So the next speaker will be myself. So I'll proceed with my presentation.
أنا هقدم سيادتك طبعا الدكتور أحمد فريد، النجم الصاعد لجامعة قناة السويس في القلب. الحقيقة دكتور أحمد فريد الإيميجينج مان لجامعة قناة السويس، ويعني صاحب شهادات كثيرة جدا في الإيكوكارديوغرافي وفي الإيميجينج إن جنرال. فأنا I think منظم very active في الإديوكيشن الطبي. الدكتور أحمد فريد مدرس أمراض القلب كلية الطب جامعة قناة السويس. أهلا بك.
شكرا أستاذ دكتورة جميلة. هو most my quiz will be about echocardiography. So we'll start by the first case. This is a pulmonary valve M mode is most likely associated with which of the following of the clinical scenarios? Look at the image at the right side. Is it endocarditis of the pulmonary valve? Is it infundibular pulmonary stenosis with prior repair of tetralogy of Fallot? Is it primary pulmonary hypertension being considered for therapeutic intervention, or it is severe pulmonic insufficiency? I will give you a poll for the selection. You can please select the right answer from this selection. Okay, so now we have most of the answer going with the third answer. That's pulmonary hypertension being considered for therapeutic intervention. And this is represent 50% of the participants. By the way, this is the right answer. The answer is 3. This is pulmonary hypertension is associated with abrupt mid-systolic closure of the pulmonary valve in about 50% of cases of pulmonary hypertension, especially when you have severe pulmonary hypertension. The appearance is thought to occur from transient traverses of the pulmonary artery to the right ventricle outflow tract gradient to the impaired pulmonary artery compliance, and it's called the floating W sign. Look at this sign again, and this is a sign of severe or significant pulmonary hypertension by any mode of the pulmonary valve. Let's move on to the second quiz. This is a 36-year-old man with prior aortic valve replacement presented with painful left toe. Transesophageal was done to rule out cardiac source of embolism. Based on these images, what is the most appropriate next step in the management? So this is the choices you are seeing now. Either you go with initiate anticoagulation, initiate antibiotics, perform coronary angiography, perform femoral arteriography, or schedule urgent cardiac surgery. Okay, we have some conflicting results here. We have almost all the selection had been selected right now, but let's see what this finding we have. We have here a vegetation over the prosthetic aortic valve and a para-aortic abscess. So what's the best approach for this patient? It's fine. Let's go with urgent surgery, as these images show valvular vegetation and large root abscess, and root abscess is an indication for urgent surgery, and the coronary arteriography is contraindicated in the presence of large aortic valve vegetation and the fibro root. So the right answer here is send this patient for urgent surgery. So moving on to the third question, we have a 77-year-old woman with prior heart surgery is referred for an echocardiographic evaluation. Based on these images, what is the most likely diagnosis? Take your time to look at these images and see what's abnormal here and what's the diagnosis. So these are the choices you are having right now. It's either isolated mitral ring annuloplasty, bileaflet mitral valve replacement, tilting disc mitral valve replacement, bioprosthetic mitral valve replacement, or mitral alveoli stitch repair with a ring. What do you think? Okay, we have here the most of the answers going with the mitral alveoli stitch with repair, and this is the right answer. We have here the figure of 8 shape of the mitral valve opening, which is the right question. These images demonstrate the double orifice that's typical of alveoli stitch mitral repair. And by 3D, we have the A2 to P2 scallop are stitched together to create a double orifice. And this resembles the appearance of the transcaster mitral valve repair, and with mitral clip is patterned on the same type of repair. So the right question here is the surgical alveoli repair. Okay, we have a 42-year-old man with exertional dyspnea, and the patient denies chest pain and ECG showing normal sinus rhythm and left one differential loop. Take your time to look at these images, and we will post the question. So, is it an idiopathic dilated cardiomyopathy? Is it a hypertrophic cardiomyopathy? Is it LV non-compaction? Is it infiltrative cardiomyopathy with restrictive physiology? Take your selection, please. Okay. Most of the answers goes with LV non-compaction, and this is the right answer. Because it's a disorder that characterized by the presence of deep intratrabecular recess with communication with the LV cavity and the prominent trabeculation in the non-compacted myocardium. And the non-compacted myocardium is hypokinetic and consists of a thick non-compacted endocardial layer and a thin compacted epicardial layer with a ratio more than 2, and the other choices are incorrect diagnosis. So this is a case of LV non-compaction. So this is my last slide here. A 34-year-old patient presented in the emergency department with a chest pain. His 2D echocardiography images are consistent with. What is the finding you can see from this echocardiography? And note that the image on the left side is the patient in the left parasternal, in the left lateral position. These are the selection. Is it constrictive pericarditis? Is it acute pericarditis? Is it absent pericardium? Or is it a pericardial cyst? So most of the answer go with the pericardial cyst, which is unfortunately, it's not the right diagnosis. This is a case of congenital absence of the pericardium, which is called the teardrop heart. The heart appears as teardrop. It's elongated of the atrium with widening of the ventricles, and it's characterized by echocardiography by the displacement, extreme lever rotation, or shift to the left side of the chest, as we had seen from the image from the parasternal lung, with exaggerated cardiac motion and abnormal septal motion, and also partial absence may lead to herniation or strangulation of the portion of the heart. So this is a case of congenital absence of the pericardium. And thank you for your time.
Dr. Ahmed Farid,
Dr. Muhammad.
thank you so much for this nice quiz and brainstorming questions. They were actually nice. And thank you for your big effort in organizing today's session. And thank you for inviting all our friends and colleagues. It was a great session, Dr. Ahmed, and hopefully this can be repeated maybe on a monthly basis, like a monthly forum or a monthly quiz, and it can get lots of interactions.
Yes.
Thank you so much for your effort, Dr. Ahmed.
Thank you. We are lucky having you with us, Dr. Muhammad. So I think Dr. Basim is in.
أنا موجود اتفضل.
Professor Basim, you can proceed.
اوكي انت عايزني اذيع من عندي؟
ولا تحب حضرتك
يا ريت يا ريت لو من عندك يبقى رائع.
طيب حاضر ثانية.
ممكن لو الدكتور زهران جاهز يبتدي على بال ما تحضر حاجتك.
طيب.
يعني.
دكتور زهران ممكن تتفضل؟
I do not have the slides with me. Can you please share them?
ما فيش مشكلة.
When I think إنه يعني most of the meeting like this will go regarding in the way regarding development of imaging part
yes.
and its correlation to the clinical.
Yes.
الحقيقة ده very very important part إنه imaging considered as an integral part of our practice on daily basis. Thank you very much, Dr. Ahmed, for this.
It's my pleasure. Dr. Muhammad Zahran, you can proceed. This is your first slide.
Okay. So this is a 50-year-old gentleman presented to the ER by crushing chest pain. And this ECG was performed in the ER upon the patient arrival. Would you please comment on this ECG with the most striking diagnosis in this ECG?
There is some comment, Dr. Muhammad.
Yes, we are getting the comments.
Yes.
Yes, we're getting the comments on the chat box. So what's striking here, of course, is an infralateral ST segment myocardial infarction associated with a complete heart block. As you can see, that the P waves have a variable distance from the QRS complexes and they are not related to each other. So this is actually an inferior infralateral ST elevation myocardial infarction associated with a complete heart block, which usually happens with a proximal right coronary artery occlusion.
Okay, this is the second slide.
So this is a chest X-ray of a 50-year-old gentleman presented to the clinic by shortness of breath, lower limb edema, abdominal enlargement. What are the striking findings in this chest X-ray, and what's the differential diagnosis and the most probable diagnosis in such a case?
Participants can leave their answers in the chat box, please.
So this gentleman is presenting by symptoms of right-sided heart failure, of course, lower limb edema, abdominal enlargement, ascites, shortness of breath because of the big ascites pressing on his diaphragm. And now this patient did a chest X-ray showing, as you can see here, and as our friends are writing in the chat box, dilatation of all the right-sided chambers. And there's something really striking that we infrequently see in our life now, which is aneurysmal dilatation of the pulmonary artery, as you can see. This pulmonary artery is aneurysmally dilated. Past time ago in Egypt, we had an infestation with bilharzia, which we used to call bilharzial cor pulmonale, which was one of the historic causes for the aneurysmal dilatation of the pulmonary artery, which you can evidently see in this case. It's not a pericardial effusion, my dear friends. There's no pericardial effusion here. This is the massive dilatation of the right-sided chambers and the pulmonary artery in the second intercostal space, which you can see massively dilated. Usually this area is not dilated actually in the normal chest X-ray. Next one, please, Dr. Ahmed.
Okay.
So this is the radionucleotide perfusion scan, MPI, myocardial perfusion imaging, for a 60-year-old gentleman referred to perform this investigation with the rest and the stress images taken. The upper line in every image is the rest image and the lower line is the stress image. And as you can see, there's a defect here. Which artery is most probably affected according to the defect that you see in those images?
And I note, Dr. Muhammad, that the rest images are the above images and the lower images
Yes.
are the stress images. Okay?
Yes, the rest is the R, the above ones, and the stress are the S, the lower ones. And the defect is obvious. So usually, which artery is supplying this defected area? So a
We have
trick
some
to read the
conflict.
MPI.
Yeah, we have
Yes.
some contradicting data in the chat box.
I'm giving the friends a tip here. To read the MPI, maybe the trick, which is easier a little bit, is to look at the lowermost one where the ventricle is cut in a circular fashion. This looks more or less as the parasternal short axis view by echo, where you can see the left ventricle as a circle, and you can easily identify all the walls exactly like the echo. So I think that the defect is localized more to the inferior wall and a little bit to the lateral wall. So this goes with a right coronary artery, this goes with a circumflex, but it does not go with an LAD. So right coronary and circumflex both can supply this area, but usually it's not the LAD. Next one, please, Dr. Ahmed.
Okay.
This is a 35 years old gentleman who did a 12 lead ECG at rest, and then he did a Holter recording because he was referred by his cardiologist for repeated attacks of syncope. And as you can see, I'm offering you the 12 leads ECG and the Holter recording, which recorded the finding that you see down there. So what's your diagnosis? So we're getting all the causes of syncope in the chat box. Which one of them? The right answer is in the chat box, actually. Which one of them is the right answer? Usually when we're young residents, we were taught to look at the T wave between two complexes. Usually the T wave follows the complex that precedes it, and it's not in the middle between two complexes. So if you find the T wave striking your eye in the middle between two complexes or even beyond the middle, then definitely you don't need a calculator. This is a long QT syndrome. So as you can see here, the T wave is very obvious to be exactly in the middle between two complexes. So this is a long QT, as you can see. And in the Holter strip, this gentleman got a VTAC or VF associated with the long QT syndrome. Next one, Dr. Ahmed.
Okay.
So this is a 60 years old gentleman, which presented by heart block, and then he performed a dual chamber pacemaker implantation. And then the patient complained of chest pain and shortness of breath. So what do you see in this X-ray that explains this complaint related to the procedure? There's a complication that happened here.
See you inshallah. Bye-bye.
Yes, exactly. You have a jet black opacity, of course, opposite the right lung, and the right lung tissue is collapsed down there. So this is a right-sided pneumothorax, complicating the implantation of the dual chamber pacemaker. This was an easy one. Next one, Dr. Ahmed.
Okay.
So this is the other one. This is a 55 years male patient that performed the 12 lead exercise ECG. This is figure A, represents the 12 lead exercise ECG at stage 3 of the exercise test. And figure B represent what happened during the recovery period. So what's the diagnosis of this test? He's a 55 years old gentleman. So in figure A, there is ST segment depression and T wave inversion, which are significant, associated with the chest pain, denoting a positive exercise test for ischemia. And in figure B, during the recovery, he developed unsustained ventricular tachycardia, which is a sign of grave prognosis, which means that this is a very proximal LAD occlusion or maybe a left main equivalent. So this is a positive exercise test with a high risk criteria of developing VTAC during the recovery. I think everyone got this one right. Next slide, please, Dr. Ahmed. Well, this is a 70 years old gentleman experiencing attacks of palpitation associated with syncope. And he did a Holter monitor. So this is the Holter of this patient. According to what you see on this Holter, what's the diagnosis of this 70 years old gentleman? So everyone is getting the right answer here. This is an old gentleman with degeneration of his conduction system. He has attacks of atrial fibrillation. He has attacks of sinus poses and heart blocks, and they are alternating together in tachycardia and bradycardia. This is called tachybrady syndrome or sick sinus syndrome. That's absolutely right. Everyone got the right diagnosis. Next one, Dr. Ahmed, please.
Okay.
So this is an intracardiac pressure tracing with a pull out of the catheter from the left ventricle towards the aorta. And there's a finding here in this pressure tracing, which correlates with one of the two imaging procedures on the echo. Echo number A and echo B. Echo A, the pathology is, as you can see, thickened aortic valve. So this is valvular aortic stenosis. And echo B is a subaortic membrane. So this is stenosis at the valve, and this is stenosis at the subvalvular area. And this is the pressure tracing. So this pressure tracing correlates with valvular or subvalvular aortic stenosis. Yes, everyone's getting it right now, because so long as the left ventricular diastolic pressure is reading a 0, so you are still inside the left ventricle. So it was 240 over 0, and then the pressure dropped to 120 over 0. So the obstruction is still inside the left ventricular chamber. If you got this pressure gradient with a diastolic pressure of 60, 70, 80, 90, 100, then you cross the aortic valve and you get the diastolic pressure of the aorta. So since the pressure tracing showed the pullback pressure gradient point with a diastolic pressure of 0, then you are still inside the left ventricle. Then this is a subvalvular obstruction. Next one, please, Dr. Ahmed. So this is the ECG and the hemodynamic tracing of a patient before and after a procedure, which is commonly done nowadays. So what is the findings at the baseline and the post-intervention? And are these results satisfactory or not? The ECG shows a dual chamber pacemaker. Yes, there are 2 spikes. And the pressure tracing shows something else. The pressure tracing on the left side shows a systolic pressure gradient across the aortic valve, denoting severe aortic stenosis. And on the right side, yes, as everyone is replying now, the procedure was done to solve this stenosis. And as you can see that the systolic pressure gradient now is 0. The systolic pressure is equal between pre and post aortic valve, which denotes that the TAVI procedure or the balloon aortic valvular dilatation is satisfactory. Yes. The dual chamber pacemaker usually associates the TAVI procedure with the long valves like the core valve because it causes a compression of the interventricular septum, which carries the conduction system. So associating the dual chamber pacemaker will make it more towards a TAVI procedure. Next one, please, Dr. Ahmed.
Okay.
So this is a 30-year-old lady presenting to the ER with a sudden acute attack of chest pain and dyspnea. And as you can see, there are 2 CT scans, number A and number B. Each one of them shows a finding. Which one of them matches the ECG? Yes, everyone's getting it right. So this is a case of pulmonary embolism. And as you can see, the thrombus is causing a filling defect towards the right pulmonary artery A, but B actually shows another cause of chest pain, which is aortic dissection involving the ascending and the descending aorta, as you can see the flap there. But the CTA matches the ECG and matches the clinical scenario. CTB does not match this clinical scenario.
Yes. The ECG is showing sinus tachycardia with the classic.
Yes, sinus
S1
tachycardia with S1, Q3, T3,
That's classic.
suggestive of pulmonary embolism,
Yes.
which goes with the clinical data described. I think this is the last one.
Yes, it's the last one.
Thanks a lot, Dr. Ahmed.
Thank
I
you,
would like to
Dr.
دكتور
thank you so
زهران
much for your
دكتور
big effort.
محمد زهران استاذ القلب جامعه عين شمس
Professor Jamila, thank you so much.
حاجه عظيمه جدا كالعاده يا باشا بتمثل الجامعه العريقه يعني منورنا يا بيه
ربنا
منورنا يا
يخليك
فندم دكتور زهران ربنا يبارك فيك يا بيه
والدكتور باسم وكل الإخوة الأفاضل.
Thank
ربنا
you very
يحفظك.
much.
دكتور باسم الظريف
you.
منورنا وكل
ربنا
الحاضرين
يبارك فيك.
منورين طبعا كالعاده يعني رمز معهد القلب القومي يعني.
Thank you. تسلمي تسلمي.
الاستاذ العظيم ربنا يبارك شكرا يا بيه.
ميرسي يا دكتور زهران ربنا يبارك فيك.
عفوا دكتور باسم شكرا لحضرتك يا فندم.
شكرا دكتور محمد.
To the point.
very challenging و interesting و teaching بصراحه حاجه جميله جدا يعني.
شكرا جزيلا. شكرا لحضرتك وشكرا لحضرتك. شكرا.
دكتور باسم I will start sharing الفيديوز اللي حضرتك بعتها فيديو باي فيديو كده.
I'm ready.
اوكي.
دكتور باسم ظريف انا عايزه اقدمه بقى الحقيقه لان الدكتور باسم ظريف يعني مش نجم الانترفنشن بس هو نجم البريفنشن والانترفنشن from prevention to intervention وهو الحقيقه عمل طفره كبيره جدا في معهد القلب القومي بصفته نائب المعهد في الابحاث. فانت منورنا يا دكتور باسم ودايما ليك ايادي بيضاء على طب القلب في زماله القلب المصريه لشباب الاطباء. مفيش حته انت سبتها بدون انجاز كبير.
ربنا يبارك في حضرتك ده من ذوق حضرتك بس وثانك يو يعني انا ما استحقش كل الكلام ده.
I think our participants
طبعا انا
online.
انا already we are already having this subcostal view with 2D and the to the left side and to the right side is a color flow.
This is the multiple choice questions about this image.
Yes, according to the image and according to the flow that showed a mosaic on color Doppler. Most probably the defect is ASD, PSD, LV2RA shunt, and double outlet right ventricle. انا عارف انه في ناس قريب من الناس اللي معانا انا رجعت الاسماء وعارف انه في ناس يعني are very يعني dedicated للايكو كمان.
لا احنا معانا ناس شاطرين جدا يعني اجاباتهم معظمها في تو ذا تارجت يعني. احنا معانا most of the answer going with the left ventricle to right atrium.
Yes, let us verify the subcostal view and to the upper right عند الساعة 12 ل2 ده الليفت اتريوم، والرايت اتريوم هو والرايت اتريوم هو اللي جنبه على طول وبينهم الانتر اتريال سيبتم، ثم الترايكاسبيد فالف تقريبا عند الساعة 9 في انا بوصف الرايت سايدد موفي. الترايكاسبيد فالف عند الساعة 9 ثم الرايت فنتركل تحته على طول ما بين 9 ل 6 من 9 ل 6 مساء في الايكو. بعد كده جاي من الناحية الثانية between الرايت سايدد chambers الليفت سايد، وفي واضح جدا الموزايك فلو جاي من left side. في حالات ال ASD البريمم بنلاقيها انه shunting from left atrium to the left ventricle to the right atrial shunt. مش جيلبرت shunt، دي جيلبرت دي liver disease، جربودي مش جيلبرت، حد قالها. ثانك يو اللي حاول بالظبط كده. نيكست يا باشا. الاورينتيشن للاناتومي كلير ولا مش كلير قبل ما ننقل؟
I think الدنيا كلير ولا في حاجة مش باينة؟ The next
and now we'll go to the intervention. حد كان presenting for intervention to the right coronary artery, and during the procedure the patient was crashed, and this is the videos showing what's going on, and the question is what is this and how to manage.
So the choices are the RCA dissection, RCA perforation,
okay,
RCA and aortic dissection, RCA hematoma extend to aorta. Make your choices, please. Okay, just launch the poll for you. Okay.
طيب هو اغلب الاجابات ناحيه
RCA واورتيك dissection.
Yes، هو ده most probably related، ممكن يكون من اكتر من حاجه. ممكن most probably most common scenario في الانترفنشن ده انه يكون related للجايدنج والديسكشن حصل due to the tip of the guiding، وممكن يكون نتيجه الستارت اوف وايرنج وات ايفر، لانه احيان كتيره ممكن بعد البري دايلاتيشن you lose the wire and you lose the system، وتيجي تدخل تاني تخش في السكشن فلاب وده يبقى اكستندد ناحيه الاورطه. في الحقيقه this is a very serious complication، وحد لو يقدر يكتب في الشات any lines of طبعا this is regarding the diagnosis is correct اعتقد واغلبيه الناس عرفته، لكن if there is any more data about how to manage. Catheter against the wall. Thank you, Fatma. Immediate aortic ostial stenting. Okay. صديقنا الدكتور زهر do ostial aortic stenting. Okay. Then after that, okay. Dr. Zahran suggesting stenting with some protrusion to the aorta، يعني نسيب 1 or 2 struts او يمكن يعني 2 3 مللي protruding from the stenting to the ostium of the RCA into the aorta. But I think انه بعد كده we have to bring the يعني watchful follow up للعيان، وممكن نبص عليه بصه بالسي تي to follow the section في الاورطه، لانه الديسكشن ده طبعا احنا مش عايزين نخش في الجريدز بتاعته لان هي ليها تفاصيل كتير، لكن اتليست you should follow after stenting and going. واضح انه المانوفرنج هنا ناحيه تم ناحيه stenting up to الاورطه with some protrusion into the of the stent from the RCA to the aorta. وبعد كده اتعمل CT للعيان ومشي بشكل conservative. ثانك يو دكتور فريد. اللي بعد كده فولو اب باي ايكو. ماشي، بس فولو اب باي ايكو ده عشان ايه؟ احنا محتاجين نشوف الديسكشن فلاب، وده مش هيبقى احسن حاجه في الايكو. This is a classic 4 chamber view echocardiography 2D, and this is the options about how to manage this complication. Yes.
Oral anticoagulation, dual antiplatelet including ticagrelor, triple antiplatelets with clopidogrel, and triple with ticagrelor. So most of the answer is going with oral anticoagulation, 71% of the participants.
هو في الحقيقه ده this is a catastrophic event. طبعا احنا شايفين انه الليفت ventricle is an extremely hypokinetic وفي epical thrombus. شكلها الثرومبس دي اللي هي بتعدي من الفنتريكل للاتريوم على الرايت سايد بنسميها ثرومبس ان ترانزيت، وبرده ممكن دي نسميها ثرومبس ان ترانزيت. فاعتقد انه العيان ده if he sustained الاكيوت ايفنت اللي هيحصل والمايجريشن الثرومباي دي ناحيه الاورطه وما راحتش للجريد فيسلز اوف ذا نيك وراحت تو ذا لور لمب او وات ايفر، يعني اذن would be an ischemic manifestation of this thrombi. Definitely the patient ده for oral anticoagulation for life if he sustained the acute event. This is an important part. طبعا احنا كنا سالنا على اللونج تيرم مانجمنت، لكن definitely الاكيوت مانجمنت وات ايفر بقى راحت البرين يبقى definitely she it has some sort of thrombectomy او mercy device to have thrombus aspiration to the brain، او لو راحت whatever لاي حاجه من الفاسكولار territory والفاسكولار branches but later on this patient for anticoagulation. بعد كده لانه underlying pathology والليفت ventricular dysfunction هيبقى having the same effect. بالمناسبه الاي سي جي واضح تحت انه العيان ساينس بس بتجيله ventricular ectopics كتير. بعده يا باشا.
I think ده اللي جاي ده اخر حاجه دي.
اوكي. الباثولوجي واضح قوي ويعني ما بيحتاجش very good experience لانه الفور تشامبر بيبقى diagnostic ليه. فلو احنا عرفنا الدياجنوز بتاع العيان فاحنا بنسال على البروميننت برزنتيشن، ديسني ولا بالبيتيشن ولا ساينوزس ولا ايزي فاتيجابيلتي ولا اول ولا نان.
طبعا الدايجنوزس is clear يعني this is a Stein anomaly يعني just to be aware يعني. I think ان معظم الناس كلها قايلين الاجابه في الصح يعني ان all of the above could be the presenting symptom for this condition. راي حضرتك دكتور باسم؟
very clear. طبعا البشتاين ممكن يبريزنت very early لما بيكون معاه اي associated anomaly، لكن بعض الاحيان البشتاين بيكمل لحد الايرلي تشايلد هود، وطبعا definitely في المايلد فورم ممكن يبقى جاي باريزميات لانه بيبقى معاه بري اكسيتيشن واكسسوري باثواي واحد او اكتر، او يجي بالموست كومن برزنتيشن اللي هو الديسنيا والايزي فاتيجابيلتي نتيجه ديكريز الكاردياك اوتبوت، والسيانوزس از فيري كومن لانه الرايت اتريال بريشر العالي الى حد ما بي sometimes لما يكون معاه other abnormality بيحصل ريفيرس شانت وممكن يبقى one of the presentation is Thanos. Thank you so much. I will really enjoying this day. Thank you, Dr. Farid.
We are very happy دكتور باسم على this يعني very challenging cases. والحقيقه يعني انا اول حد جه في دماغي لما حبيت
مالك يا احمد طلعت ليه؟
كان لان
كبير
احنا لما شفنا لحضرتك حاجات قبل كده التريسنج، كان في لحضرتك تريسنج قبل كده انا حضرته في المعهد، حاجه يعني كانت very challenging و very educational، يعني we are very happy ان
ربنا
حضرتك معانا
يخليك.
النهارده.
Thank you very much. Thank you.
دكتور كريم محمود معانا.
معاك يا دكتور احمد.
اهلا دكتور كريم، اهلا وسهلا.
ازيك يا دكتور احمد؟ Thank you for kind
allow me to
invitation دكتور
introduce
احمد.
دكتور كريم. طبعا هو دكتور كريم غني عن التعريف، ولكن دكتور كريم assistant professor of cardiology كايرو يونيفرسيتي، وطبعا واحد من يعني البيج ستارز في الانترفنشن وفي الايمجنج وفي حقيقه في كل حته. يعني ربنا يديك الصحه دكتور كريم. يعني هو طبعا هيقدم لنا اخر حاجه في السيريز دي النهارده ان شاء الله. تحب البرزنتيشن اعرضها من عندي ولا هتعرف تعرضها من عند دكتور كريم؟
بليز يا احمد من فضلك.
اوكي مش مشكله.
Thank you for your kind words Ahmed, Professor Ahmed Farid, and thank you for kind invitation, Professor Jamila Nasr and Professor Ahmed Farid. This is a very interesting forum. I believe we all learned something today from all the tracing that presented with our colleagues.
Okay.
So to start, we have a 5 tracing. This is the first one of ECG of a 63-year-old male. He is known to be hypertensive and CKD. So we have some feature in this ECG, and I believe this is the multiple choice. This ECG shows hyperkalemia, hypercalcemia, hypocalcemia, hyperkalemia and hypercalcemia, or hyperkalemia and hypocalcemia.
Okay, I see that most of the participants have selected the first answer, the hyperkalemia.
So thank you for their response. Actually, this ECG showed both hyperkalemia and hypocalcemia. Let's see, this is common in the patient with CKD. Can we show the ECG again, Ahmed?
Okay.
So we have here characteristic features of hyperkalemia, such as a peak T wave, as we can see in the inferior leads, as well as in the some leads such as V4 and V5, together with widening of P wave and prolongation of PR interval. These all are criteria of hyperkalemia. However, we have also prolongation of a QT interval without much affection of the T wave. This is a classic of hypocalcemia. So the flattening of ST segment and prolongation of QT together with the other criteria of hyperkalemia. So these patients have a combined hyperkalemia and hypocalcemia, which is a characteristic of a patient with CKD.
Okay.
So the next one. So take a look to this X-ray. We can look to the multiple choice and get back to the X-ray. This X-ray shows all the following except pulmonary congestion, intravascular device, tracheal shift, or cardiomegaly.
Can I have the picture somewhat magnified? I think it's too small for the screen.
You can do that, Dr. Basim.
ممكن حضرتك دكتور باسم create in full screen. Okay, we have a very contradicting data. أنا تقريبا معلمين على كل السلكشنز تقريبا the same value, intravascular device, tracheal shift, and cardiomegaly.
So this is a tricky one. Let's see. If we look to the X-ray, we have here a pulmonary congestion, as we can appreciate. So yes, we have a pulmonary congestion, of course. Let's take a look of the X-ray, Ahmed.
Okay.
We have a lung congestion, as we can appreciate in both lungs. We have actually a cardiomegaly. If we look to the cardiostatic ratio, it's increased and indicating a left ventricular enlargement. And if you look to the site of opposite to the pulmonary and aortic knob, you can appreciate the presence of some artifact. It's not artifact. It's the presence of intra-aortic balloon. Here you can appreciate this is an X-ray of the patient with intra-aortic balloon. You have a white a white marker inside the aorta, indicating the presence of intra-aortic balloon in this patient with severe heart failure. The only exception that is not present is tracheal shift. The trachea is placed. There is no tracheal shift here, and all other findings are present, which are pulmonary congestion, cardiomegaly, and intra-aortic balloon. So this is an X-ray demonstrating how to see an intra-aortic balloon in a patient with heart failure.
Great. Next slide.
So this is a transesophageal echo.
Unfortunately, it's not playing, Dr. Karim. Unfortunately, it's
so
not
can we go back to the X-ray, please, Ahmed?
Okay.
Because some said that they can't see the. Can we do can we use the pencil or the pen
yes
methods for demonstration of the intra-aortic balloon, Ahmed?
Okay.
Can you help me with that?
I'm trying to do it. Okay.
So I see the marker. Yes. Thank you, Ahmed.
Okay.
Here is the tip of the intra-aortic balloon that's placed inside the aorta. And you can see the intra-aortic balloon in X-ray as that. Not the full balloon. You see only the tip of intra-aortic balloon, the radio-opaque marker of intra-aortic balloon. So this is important because you should, if you have a patient with intra-aortic balloon and you need to monitor and evaluate the position of intra-aortic balloon through the X-ray, so you need to know how to see the intra-aortic balloon in X-ray.
Okay.
Okay, next one.
Okay.
Thank you so much, Ahmed.
Okay,
This was very helpful.
Okay. So we have to skip this one because it's not playing. Okay.
Okay. So can we get back can we get back to the TT, Ahmed?
Okay.
If we look to the TE, this is a bicaval view. Here you can appreciate, Ahmed, can you help me with the superior vena cava?
Yes, this is the superior vena cava. Do you see it right now or not? Okay, this is the
yes.
vena cava. This is the vena cava, and this is
yes, and this is the left atrium, and this the right atrium, and between the interatrial septum, and we can see the interatrial septum is divided or cleft. This is a characteristic of patent foramen ovale, and we see a structure at the site of the patent foramen ovale. Unfortunately, we have a video, but it doesn't move. It doesn't play. So we have a structure that's freely mobile and traversing the intraventricular septum. The patent foramen ovale. This is suggestive of a thrombus in transit. Yes. Thank you, Yusuf. This is indicating of thrombus in transit that can be appreciated in some cases of pulmonary embolism.
Okay. Unfortunately, the
This is
video
also not playing.
yes.
Okay, sorry for that. So,
Okay.
okay, I believe this is the last image.
Yes, this is the last.
This is the M mode, and we have an abnormality here. So, what do you think the abnormality seen in the M mode?
Okay, so most of the answer is going with mitral stenosis, 50% of the participants. And I have a word to say about M mode in general. M mode, though it's old, it's still very valid in a lot of diagnoses. And we should try to read more about an M mode because you can diagnose a lot of things based on the M mode. So it's now underused a lot because of the invention of the new techniques like the spectral tracking, the advancements in the 2D and the 3D, but still the M mode has a lot to answer and to give you about your study.
Thank you, Ahmed. And because of that, I choose to show one of M mode tracing.
Yes.
This is actually an mitral stenosis M mode. We can appreciate that we have a concordant motion of yes, and thank you for you all for getting that. We have a concordant motion of the both leaflets. This is due to the fixed posterior leaflet, and we can appreciate the heavy thickening and decalcification of the valve that is apparent on the M mode. So the concordant motion of the both mitral leaflet together with the thickening and decalcification that is seen, this is characteristic of a significant mitral stenosis. Of course, we have the M mode can be helpful in other condition. We can such as a premature closure of the mitral valve that can be seen in the cases of acute aortic regurgitation, the systolic anterior motion that is can seen in the hypertrophic cardiomyopathy, and we can show some of them in a future presentation, inshallah.
Thank you, Dr. Karim, for this very challenging and elegant presentation, as usual.
Thank you, Ahmed. I hope they were not so challenging.
Yeah, the X-ray was very challenging, actually.
Okay.
So I would like to thank all the participants, and I like to thank all the presenters, Dr. Mohammed Zahran, Professor Bassem Zarif, Dr. Karim Mahmoud, and I hope that we can do another sessions like this because I think it's very important and it's missing, especially for the young cardiologists. So I will try to arrange another session with some traces like this. I think that will be beneficial to all. Thank you all the participants and thank you all the presenters for their efforts.
بشكرك يا دكتور احمد، حقيقي انت داينامو لهذه الايفنت فعلا. يعني you expended a lot of time preparing and taking the cases from all the presenters. Thank you very much for the effort, and I think يعني this is a museum of cases, and I think we already see a lot of experience regarding echo, pressure tracing, transesophageal, chest X-rays, ECGs, acute cardiac care, chronic cases, congenital. It's a panoramic view to the cardiology and imaging, and how imaging is a integral part of our decision making in our patients. Thank you very, very much. And I would like to thank Professor Gamila and all the presenters.
Thank you.
Thanks a lot, everyone. Thanks a lot, Dr. Ahmed and all the colleagues. I would like to announce that, inshallah, next Thursday and Friday, 17 and 18 February, in Triumph Hotel Tajammu Al-Khamis, we will have a meeting. Thursday will be dedicated also for all early career cardiologists. We will have a very strong program, including maybe 12 interesting imaging cases from all around Egypt and 12 interesting intervention cases from all around Egypt. And you are all invited to attend this event. Just send your contact to Dr. Ahmed Farid, and I will register you all to attend this event, inshallah, and we can meet each other face to face. Thanks a lot, Dr. Ahmed, and your wonderful panel for today's great event. For me, myself, I learned a lot and I refreshed a lot of my imaging lost skills. But I enjoyed the day so much. So thank you, and thank you to all the panel.
Thank you, everybody. And I would like to announce that the recording of this webinar will be available and will be published on YouTube and Facebook soon, inshallah. Thank you all for your time. See you later, inshallah.
Thank you. Salam. Salam.